Before deciding on knee surgery, it's important to understand that there are many non-surgical options. Knee replacement isn't always the only solution, and for many, it's not the first choice. When we talk about knee replacements, we're pretty far along in the process in terms of the arthritic process, which is chronic and progressive. And in many cases, there are a large amount of individuals who are told they need knee replacement primarily because they're just not responding to the other tools that are available to them in the form of cortisone injections, gel injections, all the things that are typically offered in the traditional orthopedic model. So for many individuals, yes, they have advanced arthritic processes, but knee replacement is not something that they're ready to take part in. Now, when you're ready to take part in knee replacement, you'll know it. The pain will become so significant that you can't function in your daily life. And I'm sure that many people out there have heard that from their doctor, come back to me when it's so bad that you're ready for a knee replacement. And the thing is when you get to that stage, there isn't a whole lot of cons associated with knee replacement because for the most part, that is the proper intervention at that stage of the game. But the question is, when do we make that decision, right? And how long do we live in pain in order to wait for the day that we have to go in for a radically invasive surgery? Because the downside to knee replacement that most people don't realize is that there are a large percentage of individuals who have pain post-procedure. In terms of the literature, some studies suggest 30% of individuals on the low end will still have pain post-procedure. Some suggest as high as 50%. Everybody's a little bit different, and there are a wide variety of reasons why that might occur. But for the most part, it doesn't always work, and I think that's the take-home message. The other issues with knee replacement is it doesn't restore full function. Yes, it's designed to solve for pain by removing all the pain-sensitive tissue and putting in an appliance that typically provides that patient with significant pain relief, obviously if it's successful and after the long recovery time. But essentially, it doesn't restore function to a normal state, which most people hope they can get to. The other issue is there are serious complications that can occur as a result of doing a surgery like that. It is a radically invasive surgery, and 10% of individuals do suffer complications. I would say 2% on average, based on the literature, will suffer really significant complications like infections or strokes. There could be lots of things that can occur as a result of that. Those numbers are relatively low, and obviously patients are screened accordingly prior to ever going into surgery so that they can minimize the risks for serious complications, but they do exist. There are a large amount of people for that same reason who don't necessarily qualify for knee replacement surgery because they have ultimately other comorbidities or other issues associated with their general health that put them at high risk for, invasive surgeries like knee replacement, and they're typically left, to their own devices living in pain without any other options. For many individuals, they have high expectations of what they can expect post-surgery, and they don't always come out with full function. They don't always come out with the amount of pain relief that, they were hoping for. So, for me, when I talk to individuals, I let them know that, essentially there are other options in the conservative environment that can help to get patients to pain-free, fully functional without surgical intervention, without all the risks that come with that. So before we ever make a decision to do something that is absolutely permanent in the sense of a knee replacement, we should exhaust all conservative options. And I think it's just a matter of our belief systems. Most people don't have the knowledge base to understand that, for some individuals who get a knee replacement, they don't always come out on the other side better than they are when they went in. Most of the people I speak to who have chronic knee pain, they come to me for the same reasons. Their quality of life is diminishing. They're not able to do all the things they love and enjoy. They're pretty far down the path in terms of taking part in cortisone injections, physical therapy, all the traditional stuff. They're not any better. In fact, they're actually a little bit worse. Over time, this is a progressive condition. And when they come to us, it's because they've reached a threshold where they've been told by their doctor that they're going to need knee replacement because the tools and resources that they have been providing up until this point aren't really working for them. And they come to us because they don't want that. Whether they're scared of the actual procedure itself and the risks that come with that, or they know a friend or a family member who didn't get the outcome that they want, they're still in pain post-surgery, or they had a serious complication, or something bad happened, They want to do everything they possibly can to prevent surgery. And, I get that. There's a large amount of patients with knee pain. It's a huge demographic. And many of these people just really want relief. They want to get their life back. They want to be able to function. So, what we introduce them to is regenerative medicine, or what we like to call regenerative orthopedics. And really, the simple way to understand that is we have the ability to initiate a healing process in a joint so that we can basically get at the root cause of the problem, which is the damaged cartilage that they have accrued over time. And essentially, there's a lot of really good things that come with that. So it's minimally invasive, it's outpatient, it's not a surgery. There is no recovery time. So there's very little risk associated with providing these types of resources. And for the vast majority of individuals, so long as we select appropriately, they do very well long term. In fact, there is an open-ended study. It's done by a French orthopedist. It's really interesting. So what he did is he started this study about, I think, 40 years ago now. And he brings people in who have severe arthritis, bilateral, so both knees. And what he does is a knee replacement on one side, and he does regenerative medicine on the other. These are, again, end-stage individuals, worst of the worst, candidates for knee replacement. So they typically come back about 5-6 years down the road where their pain starts to come back following the regenerative procedure, and they don't choose to do knee replacement. They continue to choose to use regenerative components. So I think that tells us quite a bit about the effectiveness of regenerative medicine and the ability of regenerative medicine to give people what they want, which is, pain-free, fully functional to a degree. And people want to keep their body parts. The most important thing that I teach is that there are multiple paradigms in healthcare, obviously, and there are a wide variety of tools outside of the traditional drug and surgical model. I think we're pushed into that model because it is the most prevalent. But it's not the only tools that are available to us, especially as we're trying to overcome and solve for chronic degenerative conditions. In fact, the drug and surgical model doesn't really work very well in chronic and degenerative conditions, whether it's a metabolic condition like diabetes, or it's a chronic and progressive osteoarthritic condition. The best we could do is manage symptoms and ultimately cut things out when it becomes severe enough. So my advice is, when you're trying to solve for a problem and when you're trying to decide which path is the best for you, obviously that's subjective and your belief systems are going to play an important role in that. But I would encourage you to learn as much as you can about other solutions and other options. Ask individuals or professionals or experts whether they can offer you some evidence, and obviously dig into the experience of those individuals, and then decide what's best for you based on what you'd like to accomplish. The most important thing I think that people miss is that they all want the same thing. They all want long-term pain relief and a return to function, but understand that things that are symptom-based, they can't provide that outcome. It's just not possible because the underlying reason that those symptoms exist are never addressed. So when we enter the traditional model and we expect that cortisone is going to solve the problem in the way that I described, it's going to get me back to doing the things I love and enjoy, and I can live the rest of my life pain-free. Just understand that those tools are not designed for that purpose. In fact, they do the opposite. They actually accelerate the problem, right? So again, I speak a lot about short-term tools. They come with a tax. They always come with a tax. It's progression or worsening of the condition, and in many cases, some of those things accelerate that process. So you really have to be cognizant of, and first come to terms with what it is that you want to accomplish, and then solve for the tools and resources that can provide you with that outcome. I think that's the most important thing. Now, obviously, it's up to the doctor or the person who's evaluating you to determine all of the circumstances that would make you a good candidate for that. And there are varying degrees of candidacy based on severity of injury, age, metabolic health, all of the above. But if you sit with someone who has some experience and understands regenerative medicine, understands both sides of the coin, they can help you navigate based on what it is that you want to accomplish. That's really the key. So really get clear on what it is that you'd like to, what you want to see your life look like in the next 5 or 10 years, and then solve for that and make sure you're using tools that can accomplish that goal. I always bring up one particular patient. We've seen thousands. This particular knee patient, he was 58, gentleman who had multiple ACL reconstructive surgeries. He was a hockey player. And when I looked at the x-ray of his knee, now he's far down the path, right? After the surgeries, obviously he had a ton of arthritis. There was very little joint space. He had screws and all kinds of things in his knee that were left over from the surgical procedures. And he was still a relatively active guy, but he had significant pain and he wasn't able to play hockey. And now he plays in a senior ice hockey league. So, he came to us and he's like, look, I'm not ready for a knee replacement. Let's see kind of what you can do. And to be perfectly honest, it was probably the worst knee I've ever seen and probably the worst knee we've ever treated. We treated him once and he's been out of pain for 8 years, plays senior ice hockey twice a week currently, still does. I'm not suggesting that that's something we should expect with every patient. He was metabolically healthy. He was an ex-athlete. So there were a lot of circumstances that put him in a very unique position. But we can see those types of things in a regenerative model. The good news, too, is he didn't have any downtime associated with the process, right? It's a minimally invasive outpatient procedure. He was back to resuming normal activities immediately following. And then over a period of time, as his knee healed, because it does take time, right? It is a time-dependent process. He was able to do more and more, was really big into exercise and physical therapy and those types of things. And he's been able to live relatively pain-free for a long period of time. You may have a lot of questions. We have tons of information and resources for you. Please comment below. We're happy to provide it.